y'all, welcome back to my channel. If you haven't been here before, my name is Julie and I mostly make content surrounding topics such as mental health, makeup, as well as music. Today's video is a mental health related video for my new Let's Get Clinical series. Today we're delving into a few mental disorders that fall under trauma and trauma related disorders in the DSM-5. However, we're also going to get into the ICD-11. If you guys have previously watched my videos, then you're familiar with this book right here. It's the DSM-5. It stands for the Diagnostic and Statistical Manual of Mental Disorders. This version was published in 2013. In comparison, we have the ICD. The current ICD is the ICD-11. ICD stands for International Classification of Diseases. According to the World Health Organization website, I'm going to read off some facts. The ICD is the global health info standard for mortality as well as morbidity statistics. It's used increasingly in clinical care and research to define diseases as well as to study disease patterns, manage healthcare, monitor outcomes, and allocate resources. More than 100 countries use the system to report mortality data, a primary indicator of health status. This system helps to monitor death and disease rates as well. In the ICD-11, we have a section entitled Disorders Specifically Associated with Stress. So these are all either stressor or trauma-related disorders. Within these, we have, according to the ICD, post-traumatic stress disorder, or PTSD, complex post-traumatic stress disorder, prolonged grief disorder, adjustment disorder, reactive attachment disorder, disinhibited social engagement disorder, other specified disorders specifically associated with stress, as well as disorders specifically associated with stress unspecified. There are some similarities and differences between the description of some of these disorders within the DSM-5 and the ICD. Although I listed a good amount to you, today I'm going to focus on 3, those being the acute form of traumatic stress disorder, PTSD, post-traumatic stress disorder, as well as complex PTSD. There are many clinical aspects when it comes to defining the diagnostic criteria for these trauma-related disorders. However, I want to get into what trauma is as a definition. Trauma is something that makes you fear for your life. Now, when many individuals think of trauma, they think of sexual assault, they think of domestic violence, child abuse, especially serving as a veteran and being in the military. However, trauma is up to the perception of the individual in so many situations that for one individual may just be hurtful or painful in a normal way where they can process the situation and move forward. That same occurrence for another individual may traumatize them and lead to the development of PTSD. Examples such as going through a breakup, losing a friend, losing a job, dropping out of school, whatever it may be. I also want to mention that bullying is finally being recognized as a trauma, and it absolutely is, and we are in a crisis in schools with kids being bullied and it being on the rise. I want to reiterate, regardless of what you've endured in life, if something has been processed by your brain, body, and spirit as traumatic, it absolutely is. That is valid. Don't let anyone compare their traumas to yours, and don't let anyone take your voice away from you. You advocate for you. If you feel you're traumatized, if you feel you're at risk of developing PTSD, although you can't diagnose yourself, I still encourage you to seek help. First of all, in the DSM-5, we have criterion for a mental disorder referred to as acute stress disorder. The first criterion states that exposure to actual or threatened death, serious injury, or sexual violation in one or more of the following ways. 1. Directly experiencing the traumatic event or events. 2. Witnessing in person the event as it occurred to others. 3. Learning that the event occurred to a close family member or close friend. In cases of actual or threatened death of a family member or friend, the event must have been violent or accidental. Experiencing repeated or extreme exposure to aversive details of the traumatic events. For example, this can happen to first responders collecting human remains, police officers repeatedly being exposed to details of child abuse, as well as mental health professionals. The next criterion states that there must be a presence of 9 or more of the following symptoms from any of the 5 categories of intrusion, negative mood, dissociation, avoidance, and arousal. And these must have began or worsened after the traumatic event or events occurred. In regard to intrusion symptoms, we have 4 listed here. The first involves recurrent, involuntary, and intrusive distressing memories of the traumatic event. Next is recurrent distressing dreams in which the content of the dreams related to the event. Next is dissociative reactions such as flashbacks in which the individual feels or acts as if the traumatic events were recurring. Next is intense or prolonged psychological distress or marked physiological reactions in response to internal or external cues that symbolize or resemble an aspect of the traumatic event. In regard to negative mood, we only have 1 symptom here, which is persistent inability to experience positive emotions, such as the inability to experience happiness, satisfaction, or loving feelings. For dissociative symptoms, we have an altered sense of the reality of one's surroundings or oneself, such as seeing oneself from another's perspective, being in a daze, or time slowing. We also have inability to remember an important aspect of the traumatic event or events due to dissociative amnesia and not to other factors such as head injury, alcohol, or drugs. Avoidance symptoms include sleep disturbance such as difficulty falling or staying asleep or even restless sleep, irritable behavior and angry outbursts with little or no provocation, so anger that does not appear to match the situation, which can typically be expressed as verbal or physical aggression toward people or objects. Hypervigilance, problems with concentration, as well as exaggerated startle response. So the startle response is, say someone drops something or there's an abrupt noise. Some individuals may be more startled than others. If you experience this symptom for any reason, it doesn't necessarily mean you have acute stress disorder or PTSD or any mental disorders of that nature. Next, we have duration of the disturbance is 3 days to 1 month after trauma exposure. So acute means immediate and short term, 3 days to 1 month after the trauma exposure. Symptoms typically begin immediately after the trauma, but persistence for at least 3 days and up to a month is needed to meet disorder criteria. The disturbance has to cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. You probably will hear me read that criterion every single time I film one of these videos. Lastly, the disturbance can't be attributable to the physiological effects of a substance such as medication or alcohol or another medical condition such as a mild traumatic brain injury, and is not better explained by brief psychotic disorder. Moving forward into our DSM-5, we have post-traumatic stress disorder criterion. There are different criterion to meet the qualifications for this diagnosis depending on if it is related to an individual 6 years and up or if it's a child under the age of 6. For today's video, I'm going to focus on adolescents and adults who have post-traumatic stress disorder and what that may look like according to the DSM. First, we have exposure to actual or threatened death, serious injury, or sexual violence in one or more of the following ways. If you go back, I listed what some of these ways are, so to not be redundant, I'm going to stop there. Next is presence of one or more of the following intrusion symptoms associated with the traumatic event beginning after the traumatic event occurred. Recurrent, involuntary, and intrusive distressing memories of the traumatic events. Recurrent distressing dreams in which the content of the dream is related to the traumatic event. Dissociative reactions such as flashbacks. Intense or prolonged psychological distress to internal or external cues related to the traumatic event, as well as marked physiological reactions to these cues that symbolize or resemble an aspect of the traumatic event. So from what I read, you can tell that there is overlap and similarities between the symptoms that exist within acute stress disorder as well as post-traumatic stress disorder. We have persistent avoidance of stimuli associated with the traumatic event beginning after the traumatic event occurred as evidenced by one or both of the following: avoidance of or efforts to avoid distressing memories, thoughts, or feelings about or closely associated with the traumatic event, or avoidance of or efforts to avoid external reminders such as people, places, conversations, activities, objects, as well as situations that arouse distressing memories, thoughts, or feelings about or closely associated with the traumatic event. Next, we have negative alterations in cognitions and mood associated with the traumatic event, beginning or worsening after the traumatic event occurred, as evidenced by two or more of the following. 1. Inability to remember an important aspect of the traumatic event, which can be due to dissociative amnesia and not other factors such as medical issues, alcohol, or drugs. Persistent and exaggerated negative beliefs or expectations about oneself, others, or the world, such as I am bad, no one can be trusted, the world is completely dangerous, as well as my whole nervous system is permanently ruined. Persistent distorted cognitions about the cause or consequences of the traumatic event that lead the individual to blame themselves or others. Persistent negative emotional states, such as being in fear, horror, anger, guilt, or shame. Markedly diminished interest or participation in significant activities. Feelings of detachment or estrangement from others, as well as persistent inability to experience positive emotions. We also have marked alterations in arousal and reactivity associated with the traumatic event, beginning or worsening after the event has occurred by 2 or more of the following. 1, irritable behavior and angry outbursts, typically expressed as verbal or physical aggression toward people or objects. Reckless or self-destructive behavior, hypervigilance, exaggerated startle response, problems with concentration, and sleep disturbance. Duration of the disturbance from these symptoms has to be more than 1 month. The disturbance has to cause clinically significant distress or impairment in all different areas of life and isn't attributable to other medical conditions or physiological effects of a substance such as medication, drugs, or alcohol. Now that you have an idea of the specific criterion that encapsulate the symptoms within either acute stress disorder or post-traumatic stress disorder, I want to move forward into the ICD-11's descriptions of these ailments and how they classify these trauma and stressor-related disorders. One important note to mention that I found in my research is that the ICD-11 does not consider acute stress disorder a mental disorder, and it's not listed in their section. It doesn't mean it's any less valid, it's just how the ICD-11 chose to classify this in a different way. The ICD-11 also claims that acute stress should only be diagnosed when the response lasts a few minutes to a few days after the traumatic event, whereas the DSM says it can be diagnosed whenever symptoms last up to a month. Here is the ICD-11's description of post-traumatic stress disorder, or PTSD. PTSD is a disorder that may develop following exposure to an extremely threatening or horrific event or series of events. It is characterized by all of the following. 1, re-experiencing the traumatic event or events in the present in the form of vivid, intrusive memories, flashbacks, or nightmares. These incidents are typically accompanied by strong or overwhelming emotions such as fear or horror, as well as strong physical sensations. 2, avoidance of thoughts and memories of the event or events, or avoidance of activities, situations, or people reminiscent of the event or events. Finally, 3, persistent perceptions of heightened current threat, for example, is indicated by hypervigilance or an enhanced startle reaction to stimuli such as unexpected noises, as I previously mentioned. The symptoms must persist for at least several weeks and cause significant impairment in all areas of functioning. To summarize that information from the ICD-11, they are looking for 3 specific aspects for an individual to be enduring in order to qualify for this diagnosis, such as having intrusive thoughts or memories of the traumatic event, avoiding stimuli, as well as being hypervigilant or having an exaggerated startle response. All of these aspects have been mentioned in the DSM-5 as well, so I would say that this one lines up pretty accurately, even though the classification of their diagnoses are a little bit different. Now, getting into complex PTSD, it is so important for us to be talking about complex PTSD as it's been recognized by medical professionals, especially clinicians and psychologists, as a legitimate mental disorder that many of us are afflicted with, myself included. Complex post-traumatic stress disorder is a disorder that may develop following exposure to an event or series of events of an extremely threatening or horrific nature, most commonly prolonged or repetitive events from which escape is difficult or impossible, such as torture, slavery, genocide campaigns, prolonged domestic violence, repeated childhood sexual or physical abuse. I also want to mention neglect here. All diagnostic requirements for PTSD are met. In addition, complex PTSD is characterized by severe and persistent problems in affect regulation, beliefs about oneself as diminished, defeated, or worthless, accompanied by feelings of shame, guilt, or failure related to the traumatic event, and finally, difficulties in sustaining relationships and in feeling close to others. Obviously, these symptoms have to cause significant distress or impairment for you to qualify for the diagnosis. Let's quickly get into the major differences between PTSD and complex PTSD. I have a cool little chart here I found. So the main 3 symptoms within PTSD are experiencing a sense of threat, avoidance behaviors, as well as re-experiencing memories or intrusive thoughts related to the traumatic event. Moving into complex PTSD, we have those three aspects: sense of threat, avoidance, and re-experiencing. However, we also have affect dysregulation, which entails difficulty regulating our emotions and experiencing strong unpleasant emotions due to repeated exposure to varying traumatic events. People with complex PTSD also endure a negative self-concept, which was previously discussed in the ICD-11's requirements for this diagnosis, in that individuals with complex PTSD experience a lot of shame and guilt, and they feel rather worthless due to the traumatic events they endured throughout their life. We also have interpersonal disturbances here, and this is a major difference. Not to say that if you have PTSD, relationships may be difficult for you, because I'm not taking that away from you by any means, but clinically speaking, from the research that's been done and the diagnostic criterion that's been published for these specific mental disorders, maintaining relationships and feeling connected to others is extremely difficult for people with complex PTSD. And I think it's really important to distinguish the difference between these two trauma-related disorders. In regard to the prevalence of PTSD, according to the DSM-5, we have an 8.7% prevalence rate for projected lifetime risk, according to the DSM-4. There's a 12-month prevalence among US adults at 3.5%, which honestly, it sounds small, but that's pretty high for the entire US population. The development and course of this disorder entails that PTSD can occur at any age, beginning after the first year of life. Symptoms typically begin within the first 3 months after the trauma, although there can be a delay of months or years in symptom onset. According to my research, in general, the prevalence ratings for post-traumatic stress disorder as well as complex PTSD are difficult to encapsulate, especially due to everyone's response to various traumatic events is going to differ. For example, if someone experienced a kidnapping, but someone else experienced losing their house to a fire, for example, their experiences are going to be different. So the way that prevalence has been measured is what traumatic events did this individual endure, and do they have the diagnosis? In regard to prevalence for PTSD, I did find information on a website that has been updated since 2019. And the National Comorbidity Survey replication conducted between February 2001 and April 2003 that represented a sample of 9.282 Americans 18 and older. PTSD was assessed among 5,692 participants using DSM-4 criteria. The estimated lifetime prevalence among adults with PTSD was estimated to be 6.8%. So the DSM-5 estimates it at 3.5%, which the previous year, the prevalence rate was that, and now it's shot up and is even higher. And get this, the gender difference is that the lifetime prevalence of PTSD among men is at 3.6% and women is at 9.7%. I don't want to get into it too much in this video, but we are in a public health crisis, not just because of the pandemic, but because we have so many traumatized individuals, children included, walking around, not getting the treatment that they need. And from the symptoms that I read to you today, I'm sure that you can't imagine how difficult this is unless you live with it. Let's wrap this bad boy up and get into treatment options for both PTSD as well as complex PTSD. Individuals with acute stress disorder will absolutely benefit from these treatment options as well. Now, when it comes to treating trauma, there are some gold standard evidence-based treatments. We have EMDR. EMDR stands for eye movement desensitization and reprocessing. EMDR is a form of trauma therapy that you do with someone who is trained and specialized in EMDR. You typically use pulsars or lights, and you go through a process where you have to close your eyes and take deep breaths. You tend to focus on one small part of a traumatic memory and start there and see where your brain goes. This is a wonderful treatment option, and I know so many people that have been helped by it, but I do want to heed a warning that this can be a distressing treatment option because it is extremely difficult to treat trauma, especially for those of us who may have complex PTSD or have endured prolonged, repeated traumas, because they can all resurface and we can actually become re-traumatized by this process. And that's the case for most trauma therapies, although there are ways to get around it, and that's why your clinician should create a treatment plan for you, because maybe EMDR is an option for you down the road, but perhaps you have to do something else first. Another treatment option specific for trauma is trauma-focused cognitive behavioral therapy, One interesting treatment option they have is prolonged exposure, which is exactly what it sounds like. You talk about your trauma and you tell the story repeatedly when you're comfortable until you feel desensitized to the trauma. This can be very re-traumatizing as well and should absolutely be done with a trauma specialist, a clinician who is highly trained in trauma, because trauma work, it's extremely delicate and needs to be addressed in a sensitive manner. You know what I'm going to say the next one is? Trauma-informed care. If you haven't watched my video on trauma-informed care, go check it out. It was one of the first few videos I did on my channel. Trauma-informed care is awesome. I feel we all should be using it. So this is more of a treatment approach from clinicians, and it's how we lead a therapy session with you. It's how we view the client. It's how we treat the client. It's full of empathy and validation and being a real and genuine person like I aspire to be at all times. It's about building the therapeutic relationship and recognizing that that relationship, that strong therapeutic relationship, is the key to helping the client recover from their symptoms and commit to their treatment. Beyond the treatment options I listed, traditional psychotherapy can be helpful. However, I would recommend seeing someone who specializes in your disorders, regardless of what disorder you have. Psychiatric medication can also be helpful in managing certain symptoms. There are medications that treat PTSD. I know I saw a psychiatrist who treated a lot of veterans with PTSD with Risperdal, which is an antipsychotic medication, and it actually helped them to experience less hypervigilance and nightmares. It doesn't necessarily mean that's going to work for you or that your psychiatrist is going to find it to be an appropriate treatment option, but there are medications out there that can be helpful if that is something you're interested in or open to. Another important treatment option for individuals with any sort of trauma-related disorder are self-management strategies. These can include self-soothing as well as mindfulness because they help to ground a person. However, I do want to mention that grounding and relaxation techniques can be difficult for some individuals with mental disorders, specifically complex PTSD, because when they attempt to engage in relaxation or grounding techniques, they can become re-traumatized. Another treatment option, this is specific to anyone who has a trauma-related disorder that is experiencing avoidance behaviors, would be exposure and response prevention, or ERP. Exposure therapy is an aspect of CBT where you can learn how to gradually expose yourself to your trauma triggers or anxiety triggers and work your way up a fear hierarchy to face your fears in a gradual, realistic way. That's all I have for you today. Thank you so much for watching. Please give this video a like if you enjoyed it and found it helpful. I'd love for you to subscribe to my channel as well. Please leave a comment down below letting me know if you have a trauma-related disorder or if a loved one does, or if you were not aware of these things. You can follow me on Instagram. My Instagram is Julie_counseling. My Twitter is JulieCounseling with no underscore, and my Facebook page will be linked down below as well. And I'll catch you on the flip side. Bye guys.